Today I'm Dr. Rajesh Shah, working as a head of the Department of Anesthesia and Pain Management at Nirmal Super Specialty Hospital, Surat. And my topic today I'm going to speak is pediatric or neonatal spinal anesthesia. So, slide is not moving. Just
Yeah.
yes. So this is one of the reference. Okay. So to start with the neonatal and spinal anesthesia, uh, this is the X-ray picture of one baby. So spinal can be done or not. This is one more picture where spinal can be done or not. So yes, we have done spinal for all this kind of the babies for the surgery, anesthesia management. So today's lectures, my outline will be why spinal anesthesia in children, anatomical and pharmacological basis, and so on. So coming to the history of the spinal anesthesia, if we talk about, then German surgeon August Beer had performed it in 1898 the first spinal anesthesia block, and then onwards till world is in awe of a spinal anesthesia till today. So and in pediatric population, the first spinal anesthesia was given in 1908 by Terry Gregg. But then it was not popularly practiced. But in 1980, it's research, and in 1984, the Abejan and his colleague had concluded that for high risk neonatal and infantile surgery, spinal anesthesia is a better and safer option than the general anesthesia. And my first spinal anesthesia was the pediatric spinal anesthesia journey started in 1995. So I had given that time below 6 months of child the spinal anesthesia for orthopedic procedure. So why spinal anesthesia in children? By definition, the single prick into the intrathecal space by the local injecting the local anesthetist drug provides the safer and better hemodynamic stability for the anesthesia management of so many surgeries. And why spinal? Because general anesthesia drugs, what we are using, is known to cause neuronal damage, which increase the apoptosis also, which causes the cognition and behavioral changes, and that depends on a duration of GA exposed to the baby and drugs used, doses used for that. So, and particularly when it comes to associated comorbidities like babies are in sepsis or babies are in having a cardiac congenital anomalies, and in those kind of the cases, general anesthesia becomes more complicated also. So, spinal anesthesia in neonatal and pediatric is safer because uh, it provides a better hemodynamic stability. As these babies have a underdeveloped sympathetic system with parasympathetic overdominance, and uh, having a less venous capacitance into lower part of the body, so that provides a better hemodynamic management. It prevents the neuroendocrine responses towards the surgical stimulations or the surgery. Uh, and of late, with the availability of the bisulfite free, like isobaric drugs usage, had eliminated the risk of damage associated with the intrathecal injections. As previously, it was like with the hyperbaric drugs is known to cause the TNS like symptoms, and it was more into the pediatric. So that was the reason there were a lot of hesitations was there for the spinal anesthesia in neonate and this infant or pediatric population. So, uh, with the spinal anesthesia, uh, it it provides the single pick can provide or solve a lot of purposes, almost all the purposes of the anesthesia, like it provides good post-op analgesia, as we already talked, good intraoperative stability, hemodynamic stability, and good post-operative analgesia. Less post-operative nausea, vomiting is associated with the spinal anesthesia. Early recovery of this alertness, as they are not sedated much when spinal block is given. So they recognize the mother very early, and early NBM clearance is also possible. They void earlier because usually without adjuvant, if we use drugs, then duration is just shorter for the spinal anesthesia. So voiding becomes earlier, and all this fulfill the criteria for the early discharge from the PSU, and that is good for the uh, daycare surgeries also. The most important thing I will stress out with the spinal anesthesia is it allows us to avoid the airway complications, as it allows us to avoid the airway interventions or airway handling. And all the pediatric anesthetists, we know there are very frequent laryngospasm and bronchospasm occurs with the GA, either during incubation or more during the extubation. So that is also one of the biggest advantage for that. We already talked about less hemodynamic changes, so that causes more less heart rate variation. And the one research paper was there is there that claims or conclude that the inhalation general anesthesia causes 28% more hypotension than the spinal anesthesia. So, looking to all this in spinal anesthesia is a safer option. And what kind of the surgeries can be done under spinal anesthesia? So, conventionally or traditionally, we are being taught that the surgeries below the Ziphod process, so including abdomen or upper abdomen and lower abdomen areas or orthopedic surgeries can be done with the spinal anesthesia. That includes general surgery, urological surgery, or orthopedic surgery, whatever. But in my opinion, I will insist preferably to prefer spinal anesthesia where there is a chance of post-operative apnea, like babies who have a post-conceptional age is less than 60 weeks and have a chance of post-operative apnea, which can lead to the disastrous complication. So that is where it should be preferred. The patient who comes with the suspicious history of the malignant hyperthermia or some death related, suspicious related to the malignant hyperthermia, there it is having a very good role. And as already we had evidence, one patient, the 16-year girl came to our center with, before that, she roamed around multiple centers for the surgery. She had a bilateral fibroadenoma, but her brother had a death during under anesthesia, and they possibly were telling that increased temperature. So we proceeded with the spinal anesthesia, thoracic segmental spinal anesthesia for that girl, and bilateral fibroadenoma excision was done. So again, bronchopulmonary dysplasia is again one of the indication where we should avoid airway handling as far as possible. Though that makes more safety. Anticipated difficult airway, again, there is a two school of thoughts. One group think of that first we should secure the airway and then do whatever we want to do. But the people like me probably will think we should be ready with all the gadgets available and all the emergency things, and then don't intervene with the airway manipulation, directly go for a spinal anesthesia or regional anesthesia. Hyperreactive airway, again, in the neonatal and infant population, it is a very common thing. Recurrent upper respiratory tract infection is continuously happening in those childs. So sometimes it becomes difficult to make them fit for the general anesthesia, or that may lead to the airway complications also. And patients who have a congenital abnormalities or congenital heart disease and posted for the non-cardiac surgeries, in those cases also spinal anesthesia is having a age over the general anesthesia. Daycare surgeries, as I already had described, that what are the spinal anesthesia fulfills all the criteria for the early discharge of the babies from the PSU or from the hospital. So that is also. So these are the list of the surgeries which can be done under the spinal anesthesia, all general orthopedic surgery or urological surgeries. Uh, And coming to the contraindication, in neonatal and infant population, the most important uh, challenge to deal with the parents rather than to deal with the anesthesia management of the babies, because they have a very high level of anxiety when their baby is going for the surgery. So, how to take a consent for the spinal anesthesia for these babies? I used to explain that if we give a general anesthesia to this baby, the multiple drugs will be used. We will be handling the airway. That airway complications are like this, and that can happen with that. But if we go for a spinal anesthesia, the single prick injection will solve this purpose, and there will be everything will be fine. And most of the time, parents were agreed to give the consent for spinal anesthesia. Even coagulation abnormalities, as we all know, infection at the puncture site, or a severe sepsis where the chances of the infection to the dura also are high, and local anesthetic allergy. So, conventionally or traditionally, we think of relative contraindication for the spinal anesthesia as spinal deformities or abnormalities, or like tough hair is there or dimple is there. All these are considered spina bifida. All these are considered to be a relative contraindication. But we have done a lot of surgeries with under spinal anesthesia with these all deformities. We have a series of manual repair also under spinal anesthesia. Uh, so that is also relative contraindication. We can go for spinal anesthesia in those kind of those things. So coming to, is spinal anesthesia safe in neonatal infants? So anatomical basis, if we think of, as we all know, in neonatal infant, the spinal cord extends up to the L3, where conus medullaris extend up to the S3, and in adult, cord extends up to L1, 2, and conus medullaris up to S3. So conventionally, we are being taught that we have to do a dura puncture at the lumbar level below the intercostal line, which passes in the neonatal and infant at the L5 S1 level, and in children it is L4 5, and adult it is L3 4 5 4 5. So that is what traditional practice to do a dura puncture or a lumbar puncture at this, because we do it at a lumbar level, we call it a lumbar puncture. But with the invention, so this is a pictorial representation. But with the invention and more diagnostic precision with the MRI and all that thing, if you look at this picture, this will be more detailed described by the Dharmi, but I will just state a statement that at the highest at the T5 dura to cord distance, and even thoracic and lower, upper thoracic and lower thoracic level also dura to cord distance is higher than the lumbar level. So it provides a safe injection to that level also. Even in this is a pediatric patient slides. So coming to the pharmacology and pharmacokinetics of the drugs used for the spinal anesthesia, when we are talking about spinal anesthesia, the first question will come into the mind. Till the date, we were hesitated to do the, then what change now? So there are a lot of availability of the drugs like hyperbaric drugs, hyperbaric bupivacaine 0.5%, hyperbaric ropivacaine 0.75% is available. Isobaric drugs are now available, that is ropivacaine 0.75%, levobupivacaine 0.5%, and nowadays isobaric bupivacaine is also available. So coming to the hyperbaric drug, if it is injected, it gives traditionally it was believed that it gives a better relaxation and better dense block. But in our experience, we have a same relaxation and block with the isobaric drugs also. With the hyperbaric drug, to some extent, block can be controlled or controlled by the positioning. But in neonatal, it's usually tubular spine without the curvatures, where cervical curvature develop at the age of the around 6 months, and thoracic curvature develops around 12 months of age. So even we cannot completely control in that neonatal population with the positioning also, because there will be a chance of going higher level with injected drug and dose level. Even with the isobaric drug, again, if it is a dose dependent and independent to the positioning, but there are also chances of going higher.
Rajesh, I will interrupt you.
Yes.
There's no coordination between your slides and your
Yeah,
talk.
sure.
Can you please take care? Thank you.
So, sorry.
Yeah.
So there is a chances of even isobaric drugs to get sprayed at a higher level because in neonatal, as there is an absence of curvatures. So But if it is understood well, doses and drugs, which will describe for the segmental, will be described by the Dharmista, then it is quite safe. Adjuvants we can use for the spinal anesthesia in neonatal and pediatric. As a clonidine, I think FDA approved as a 1 microgram per kg, but dexmedetomidine is not an FDA approved, but it's not any illegal. It's 1 microgram per kg and maximum up to 5 microgram per kg can be used. And with dexmedetomidine adjuvant using with the isobaric drugs, we have done the surgeries up to 3 to 3.5 hours also only under the spinal anesthesia without converting it to the GA because of the time duration. We are using morphine also intrathecally as adjuvant. Fentanyl also we are using. When coming to the duration and quality of the block, then if we talk about the CSF volumes in the population, so neonate have a 4 ml per kg in less than 15 kg of babies. 4 ml per kg is the volume. Out of that, 50% is remaining into the spinal canal. That's a 2 ml per kg, and it's about 50% against the in adult population. It is a 25 to 33%. So in the children, 3 ml per kg is the volume. In adult, it is in a 2 ml, 1.5 to 2 ml per kg is the total volume of the CSF. So coming to the onset and duration, in this baby's myelination is poorly developed, so it allows to have a rapid onset of a block with even lower concentration. We get a dense block also, and again endoneurium is also loosely placed, so it allows the good permeability of the drugs. So again, that gives a faster onset, high quality block with that. Coming to the CSF volume and high CSF volume in the spinal canal and associated with the high heart rate, which leads to the high cardiac output with increased vascularity, which leads to the increased absorption of the local anesthetics, and that is responsible for actually shorter duration of the drug, shorter duration of the spinal anesthesia in this population. So risk of last. These babies are at risk of last, high risk of the last, but not in spinal anesthesia. Actually, I have added this because we used to do either caudal block with spinal anesthesia or either some regional block pertaining to the surgery. So I have added this. So lignocaine and bupivacaine is metabolized by the system CYP3A4 and 7, and that leads to the actually cumulative accumulation of the metabolites, and which are again are responsible for causing the last if it is given in a high dose or as an infusion also. And ropivacaine, levobupivacaine is metabolized by CYP1A2, and that has a safer profile. Even alpha glycoprotein is lower in this population, so free drugs availability in the plasma is also high once it is injected. So that again one of the factor when it is given in infusion or in a higher bolus doses like in a block or something. So lignocaine and bupivacaine, we have not used that in infusion and not advisable also. If we want to use an infusion in the epidural, then ropivacaine 0.1%, around 0.25 milligram per kg per hour is a safer option up to 48 to 72 hours. Opioids again not advisable as because of the pharmacokinetics in this population in the infusion. So how is it done? So we have all talked about the anatomy, physiology, and history, but the main question how it should be done or how it is done for all the time. So there is a lot of technique available for doing. So how to proceed? Again, there is two school of thoughts or the few population think of that with the sucrose pacifier before taking the vein, make the child calm, apply the EMLA cream application on the back before 45 minutes, hold them into the sitting position, do the spinal block, and then uh, after the spinal block is done and effect is established, then take a vein in the lower limb. So that is the one school of thought is thinking of doing that. We have not done like this. The another school is like in a awake but in the lateral position. But before doing anything, the venous access is done. So first venous access is done. then either awake with the amla application is done in the sitting position or in the lateral position, and with the sedation also done in the lateral position. But when the lateral position is being done, be aware and be cautious that flexion of the neck should not be done in neonate or infant population, because their airway is highly collapsible and large tongue into the oral cavity also with the flexion will lead to immediate obstruction of the airway and can lead to hypoxia instant. The child decides very fast, and which leads to the bradycardia also. So please be cautious not doing the flexion. So with the sucrose specifier, we have seen the things, and for that, this toys, tablets, or VR also can help for the non-pharmacological thing. So pharmacological sedation, if we talk about in pediatric population, what can be used? Then ketamine alone can be used with the anticholinergic, or ketamine and dexmedetomidine combination can be used. Ketamine and midazolam combination can be used. Only midazolam can be used. Intranasal midazolam, intranasal dexmed can be used, or sevo mask inhalation also is used for the spinal anesthesia, to give the spinal anesthesia. So my choice how of sedation. Uh, I usually use the ketamine plus dexmedetomidine combination. So ketamine 1:1. What does it mean? I take a 50 milligram of ketamine and 50 microgram of the ketamine in 110 ml of the syringe and dilute it to 10 ml. And out of that, if the baby is of 5 kg, then the 1 ml contains the 5 microgram per kg of dexmed and 5 milligram per kg of ketamine. So I will give a 1 ml to that 5 kg baby. But if baby is not less than 5 kg, like 2.2 or 2.4 kg, then I will take 1 ml out of that 10 ml syringe and again dilute it to 5 ml, and will give 2.2 or 2.4 ml out of that diluted again, double diluted things. Why ketamine and dexmedetomidine? Because it is having a synergistic effect. The tachycardia caused by the ketamine is countered by the dexmedetomidine. Dexmedetomidine also act as an anti-sialog also. It gives a good sedation also. And most important is a respiratory profile or dynamics doesn't change with this sedation. And sedation in this lower doses cause a very good hypnotic conscious sedation, even with sedation when we do a
Like,
local
funny about
infiltration. Pardon?
continue,
With
please.
this sedation, if we do local infiltration of the skin for doing the spinal block, that we do with the 26 number half gauge needle, and take care of being only into subcutaneous, then child actually moves, but the amnesia is there. So it's a very good profile for it. Uh, the second thing, once the spinal block is done, it itself blocks the efferent stimulation to the RAS, reticular activating system, and that itself causes sedation to the child. So once the spinal block is done, the no extra sedation most of the time is required for a short duration surgeries like around 1 hour. And when we use adjuvant, if with the spinal local anesthetics like clonidine, dexmedetomidine, or morphine, they itself also leads to this sedation to the child. So these are the needle actually, pencil point needle. And but this pencil point needles, we don't have a availability for the pediatric, and also in probably we didn't get it. But if we get it, then also it is slightly blunt. We need to require higher forces, and that can lead to sudden give way to the dura also. The second thing is, in this needle there is a hole is somewhat proximal to the tip, and if you want to have a CSF flow, then we might have to introduce little more than the Quinky needle. So we actually have used a Quinky needle of 30 mm and 50 mm of 25 gauge most of the patient. So I already described this for the. So coming to the dose of hyperbaric bupivacaine, that is less than 5 kg, 1 milligram per kg, that's 0.2 ml per kg. 5 to 10 kg is a 5.5 milligram per kg, that's zero point 0.1 ml per kg, and then 10 to 15, 14. This all we are aware of the this doses. Dose formula for the segmental is a 0.035 ml per kg usually. And coming to the our experiences, what we have done, some of the cases done by our team is VSD patient with the high pH for esophagostomy and gastrostomy. Apart from routine cases, we have done like a hernia, circumcision, and so on. These are the other cases which we have reported. Also, diaphragmatic hernia in 7 kg baby laparotomies. Even spinal, we have done the surgeries under spinal anesthesia with the spinal deformities. Like I already told, meningomyelocele series we have for excision. I put this slide because of almost most of the time we were as combining the spinal anesthesia, as I told, with the caudal anesthesia or the sunblock. So if we are doing a spinal anesthesia, we must be well versed with the USG anatomy of the spine in the baby and neonates. That gives a very precise calculation of the space also, and particularly in the caudal anesthesia and more with the deformities, it provides a lot of information to inject precisely and safely for the caudal anesthesia also. So these are the few images. This shows the L3 cornus medullaris extending up to spine cases. Also we have done like hemangioma excision under spinal anesthesia, meningomyelocele various level we have done. Prone positioning cases also we have done like PSARP or sacral teratoma excisions, neonatal laparotomies in sick babies, non-hypno nevarts, so non-intubating video thoracoscopy, laparoscopic bilateral orchiopexy also done. So I rest with the things. Thank you very much. Thank you. So I hand over to the Dharmi.
Uh, Sanjay, do you want to actually do a small Q&A question session before Dharmi?
Yeah, I think it
starts?
makes sense. Otherwise, the questions can be waiting for too long.
Yeah.
So Rajesh, there are some questions in the chat
Yes.
box. So I think Dr. Muthukumar has asked a few questions.
Yeah.
One is if he's asked if the spinal, if the duration of surgery goes beyond 1 hour in preterm infants, do you prefer spinal or what do you prefer if GA is contraindicated?
No, so we have done surgeries with, as I told, up to 3 hours, 3.5 hours with the spinal anesthesia when we have added the adjuvant as Dexmed or clonidine. So
Okay.
it is not like that within 1 hour the effect gets wear off if we use the adjuvant. And in my experience, rather than hyperbaric drug, isobaric drugs are actually giving a longer duration.
Okay. And what is your first preference, Rajesh, in terms of adjuvant? Is it clonidine or Dexmed or morphine?
So what we were doing was intrathecally we were using a dexmedetomidine 1 microgram per kg up to 5 mg, and then we were combining means it's with the caudal where we used to use local anesthetics with the morphine.
Okay. So one person has asked complications you've encountered so far with spinals.
As such, no complications, but yes, in initial days when we started using morphine in a caudal, not a spinal we didn't get actually this complications, but in a caudal when we started using morphine, that time we were using around 30 microgram. In below the 6 month, it was leading to the transient apnea where we used to ventilate it with 3-4 minutes and it used to come. But then we decreased the dose up to 10 microgram kg and that was fine. Otherwise, there was no complication. Yes, once we faced the things when we had the flexion was done erratically by the staff out of our, that time we actually faced the hypoxia, but then it was corrected. Otherwise, no complications related to this actually spinal anesthesia. And
if there is no pediatrics,
yeah,
go on. Sorry, Rajesh.
Pardon?
No, if there is no pediatric spinal needle available, what would you recommend in terms of giving what needle can you use?
Yeah,
for pediatric, for neonates.
We can use our routine adult needle also. The problem occurs with the adult needle is it is a very long. So the precision of injecting will be doubtful, because then you have a very malleable needle in your hand and you are injecting from the distance. So that is the only issue. But if you can control that, I think that's not a problem at that needle.
Okay. I think there are a lot of questions coming up. So almost around 20 questions coming up. I'm not sure if we have the time to cover everything.
Can I,
Um,
sorry, Sanjay, can I quickly ask a
yes.
question, please, if you don't mind? Sorry.
Sorry, who? Yeah.
Dr. Nagendra here, sorry.
Oh, yeah, Nagina, yeah.
Hello, hi. Rajesh, thank you for such a lovely presentation. I don't do pediatrics regularly, but I think your talk really has given us a good insight as to how you guys manage anesthesia in such a complex group of patients. A couple of questions. I think we have already been asked in the chat. I missed it. Sorry. What gauge of needle would you use in, say, less than 1 year or up to 5 years?
Up to 2 years, means up to not 2 years, up to 5 years actually. We have used either less than 1 year, we have used 30 mm, 25 gauge needle, Twinkie needle, and more than 1 year, 2 year. If we feel that the 30 mm will be smaller, then we use the 50 mm needle. That is
Sorry, gauge
25
is
gauge.
25 gauge, is it, or
25
27
gauge.
gauge?
Yeah, 25
25
gauge.
gauge.
Yeah.
Okay. And I think there was another question in the chat. This is regarding the parasympathetic drive, because I think one of them has asked a really very quick question. If parasympathetic drive is already prominent in neonates, how is it? How do we say that the spinal anesthesia would be safe? I mean, how do we make sure that we don't run into any complications because of any, say, too much of drug being given or too high block?
Uh, if it is high block, then we have to manage it with routine our resuscitative measures. So if it
Yep.
happens, but
Yes.
usually with the doses what we have described, we have not faced the high block. And the second thing, we have not used atropine or glyco in any of this patient prophylactically. Sometimes in some patient when bradycardia, if had happened, then we have used, that's a different story. But we have not used atropine or glyco in any of this patient prophylactically. As India is having a summer hot climates, atropine glyco itself can lead to the temperature rises and nausea, vomiting, and all that thing. And it is not actually we. I will demonstrate some videos later. In that, the monitor is also there. You can see the heart rate also remains around 120, 110, 130 without atropine glyco also. So if we give that, I think that leads to quite high.
Okay. And
Rajesh,
finally,
thanks.
sorry,
Yes.
one final question, Dr. Sanjay. Sorry, post-op recovery, how are these patients monitored with respect to the block being monitored and with respect to how the analgesia is being monitored, if you have to make sure that the block is completely worn off?
As I told, usually we combine every time with the either regional block or caudal anesthesia, caudal block. So most of our patients are sleepy very nicely and arousable immediately for the next 24 hours. And we were monitoring in PSU for all the babies at least minimum 1 hour, and then we will be shifting them to the ward. With the in PSU, we used to monitor everything like heart rate, respiratory rate. If babies are less than 60 weeks, then apnea monitor is also there. So all this we were monitoring in the PSU.
Okay. Thank you. Thank you very much.
Thanks for the question. Thanks, Rajesh. Rajesh,
Yeah.
what I would recommend is because of want of time,
Yeah.
it will be nice if you could answer the questions in the chat box because there are almost 20 questions
Okay.
still unanswered. So
Okay.
while we listen to Dharmi, you can probably answer those questions. And any of the other panelists, if you have any experience in answering the questions, feel free to answer in the chat box. So Dharmi, would you mind starting a presentation, please? Thank you.
Sure, sir. Good evening, everyone. I'm Dr. Dharmi Patel. I'm working at present at the Nirmal Super Speciality Hospital as a consultant anesthetist. Today, I'll be presenting segmental spinal anesthesia in pediatrics, an evolving technique that offers a safe alternative to general anesthesia in selected pediatric surgery. So, in this talk, I will walk through when to use it, how to perform it, safety consideration, and how outcome compares with the general anesthesia. So these are the learning objectives. So, segmental spinal anesthesia is a targeted neurological block that anesthetize only the targeted dermatomes which are required for the surgery. So, in children, this technique is especially helpful because it reduces the systemic anesthetic exposure, avoid airway manipulation, and support sorry, support stable hemodynamics and faster recovery. It has found increasing use in abdominal surgeries, especially we started with a lower abdominal surgery, then we shifted, once we become confident, we shifted to upper abdominal surgeries, perineal surgeries and lower limb surgeries, particularly neonates and infants where the airway safety is crucial. So these are my primary indication. As I mentioned, we have started with the lower abdominal surgeries like inguinal hernia, orchiopexy, hypospadias, and lower limb surgery, lower limb orthopedic surgeries like upper cutaneous Achilles tendon tenotomy, we call it, and urethroplasty, ureteric reimplantation, circumcision, and minor genital surgery. So for the thoracic segmental spinal anesthesia, this is a technically more demanding. So performed only by experts once you become confident with the lower abdominal surgeries and to avoid the high spinal complication. In appropriate chosen cases, segmental spinal can completely replace the general anesthesia. For example, breast fibroadenoma. So let's talk about the pediatric physiology related to spinal anesthesia, especially segmental spinal anesthesia. So as we know, in neonates and infants have a higher CSF volume of around 4 ml per kg of CSF, almost double than the adult. So leading to greater variability in anesthetic spread. Reduced sympathetic tone, they exhibit milder hypotension compared with the adult, which is why the spinal anesthesia is often remarkably stable. And airway vulnerability, even if we avoid the airway instrumentation, we always must ready with the airway rescue plan because it might segmental spinal might end up with the hard spinal block or surgical stem may extend. It's depend on the surgeon. So an infant and neonate desaturate very quickly. So beforehand only we should keep the airway rescue ready. And shorter the block duration, as we know that due to faster CSF turnover, immature nervous system duration is shorter, around 45 to 90 minutes, depending on the drug we use. But as Rajesh sir has mentioned that we normally using the dexmedetomidine as a additives which prolong the surgery around 3 to 3.5 hours. In these slides, you can see the difference in CSF volume by age group. This explains why infants need proportionally higher doses per kg than the adults. CSF volume increases as a rapid rate than the body surface area and reaching to the adult volume after first 3 years of age. Now let's look at how to perform the block. These are the important consideration for the performing the segmental spinal anesthesia. We'll go through one by one. First of all, position. Position is a very important factor in determining success. You can use any of them, lateral or supine position, whichever you are comfortable with. And for the lateral decubitus position, hip and knees are flexed. As sir has already mentioned that we need to stabilize the head and head should be in a neutral position because it might end up with airway obstruction, which may lead to other complication. Now side, unlike the standard lumbar spinal, segmental spinal anesthesia targets the mid-dermatomal level of the planned surgery. So whatever the dermatomes are required for the surgery, we have to target the mid-dermatome level of that surgery. For example, for inguinal umbilical hernia, we target the T12 to L1 level. For the pyloromyotomy, T5 to T6 level. For sacral teratoma, L4 to L5 level. So in this slide, I am showing the MRI based measurement of the posterior subarachnoid space at the different thoracic level. Here you can see the targeted level are T2, T5 and T10. This measurement helps us to understand why the segmental thoracic spinal anesthesia is a feasible and safe and selected upper abdominal surgeries. If you look at the diagram on the right, the colored lines represent the depth of the depth from the skin to spinal cord. More importantly, the distance between the dura and the spinal cord. So what we can see here, the posterior arachnoid space is not uniform throughout the thoracic region. The largest distance at T5 around 8.18 mm, followed by 6 mm at the T2 and the 6.5 mm at the T10. So this increased space provide a relatively wider margin of safety when placing the needle at this level. Because of these anatomical advantages at this specific T5 level, it become technically possible and safe to perform spinal anesthesia for the upper abdominal surgery. Now let's talk about the spinal needle. So for neonate and infants, as sir has mentioned, we are using smaller size of needle, around 30 mm, a smaller length of needle with either 25 to 27 gauge. But at our center, we have just 25 gauge spinal needle available in a size of 30 mm and 50 mm. Here you can see cutting needle do less trauma because it has it can pass smoothly through the neonatal ligament, and we need stability while handling this and precise movement, especially with the neonate and the pediatric, infants. And stillness is must as a stillness is mandatory to prevent tissue coring and accidental forward jump into the needle. I forgot to mention the pencil point needles are though atraumatic in adult, but they require more force to advance through tight pediatric ligament, which may suddenly overshoot. So we are using twinkie cutting type of needle, which remains safer and more practical with a precise location. In this slide, you can see the different doses for the different type of spinal anesthesia. So dosing is the heart of segmental spinal because we have to target the proper dose according to the dermatomes. So for the standard lumbar spinal, we are using heavy bupivacaine. The dose is already described by the Dr. Rajesh Shah. For the segmental, I would focus. Here we are using isoveric form of local anesthetics, which are available as bupivacaine 0.5%, ropivacaine 0.75%, and levobupivacaine 0.5%. They have mentioned the short cases, some of are using chlorprocaine, but we never used. Here is the proper dosing formula for segmental spinal. So we are giving segmental spinal at the 0.035 ml per kg or 0.06 ml per dermatome. We have to consider the dead space of needle with 0.02 ml for 30 mm needle and 0.03 ml for 50 ml needle. So how to choose between these two formula? The first formula is 0.035 ml per kg is generally sufficient for 5 to 6 dermatome coverage. So if you have to target the more dermatome, more than 6 dermatome or less than 6 dermatome, we can shift according to the dermatomal formula, that is 0.06 ml per dermatome. So, but in both the cases, you have to target the needle exactly at the mid dermatomal level. For example, if there is a child of 10 kg posted for open inguinal hernia repair, so I would give volume of 0.38 ml at the level of T12 to L1. See, in this slide, I have mentioned that 1 ml syringe I have placed side by side intentionally to emphasize how to use a precision 1 ml syringe to measure the tiny volume. So like 0.3 ml, 38 ml. So there is a fine granulation on the 1 ml syringe. Each small marking represents 0.01 ml, which allow us to draw the drug according to desired draw. Adjuvant already mentioned. To extend, these are the adjuvant we are using. We are just using dexmedetomidine, but others we have also used in the past. So fentanyl 0.5 to 1 mic per kg. Maximum we used 10 to 15 mic. Clonidine 0.5 to 1 mic per kg, and dexmedetomidine 0.5 to 1 mic per kg. Maximum for the children we use till 5 microgram. Now, this slide summarizes the essential steps in performing pediatric segmental spinal anesthesia block. So here we begin with identifying this interspace, either by anatomic or USG guided, whatever you are comfortable with. It is very important to identify the site at first. Following this, we have to maintain the strictly asepsis to ensure the free flow of CSF and confirm the correct intrathecal placement. So local anesthetic is injected slowly using appropriate calculated dose to achieve the predictable or controlled spread. So next is positioning. Positioning become relevant only when you are using hyperbaric local anesthetics, because the gravity influence the cephalad or caudal distribution, but in segmental spinal, isobaric solution we are using, so patient positioning does not significantly affect the spread. And finally, always confirm the sensory level before incision. An important practical point from our experience is that we use all our cases with the additionally regional technique, either a caudal block or a regional block, depending type of the surgery. So it has two advantages. It provides the post-operative analgesia, and it allows us to confirm the effectiveness of the segmental spinal before incision. So monitoring during pediatric spinal anesthesia are the same as for a general anesthesia. So we use continuous SpO2, ECG, NIBP, and capnography when the sedation is added. Temperature monitoring is very essential for a specific population like infants and neonates due to higher heat loss. And emergency drugs like atropine, ADR must always be available immediately according to the dose. Like for atropine, resuscitated dose.
घेऊन इतरी बस घातली ना म्हणजे बरोबर ओळख.
Atropine, we are using 0.02 mg per kg, and ADR, one solution of 1:10,000, 0.1 ml per kg IV. Safety is a paramount. So when you are using this technique, we always be prepared with the airway rescue kit, including appropriate size of mask, LMA or ETT. You must be prepared beforehand, and precise dosing, which prevents the high spinal complication. So especially with the thoracic segmental spinal, when it should be always in incremental microdosing. It means inject 0.1 or 0.05 mm, 0.05 kappa for every time, and you have to wait until it will transfer. Like every 1 second you use 0.01 mm or 0.01 kappa. So because it leads to excessive, it may you should avoid with that. You can avoid the excessive high spinal block. You may avoid severe hypotension, or especially with the cardiac sympathetic blockade. And apart from that, vasopressor should be available. We are using noradrenaline 0.05 microgram per kg per minute, or adrenaline 0.05 microgram kg per minute. So what are the benefits? Benefits of segmental spinal anesthesia are rapid, reliable sensory block. You can avoid by using spinal anesthesia, minimize the opioid use, which may leads to lower respiratory depression. Lower down the respiratory depression, and you can avoid the airway manipulation and its complication like bronchospasm, laryngospasm, or apnea. And as I mentioned, most of the time it maintains the stable hemodynamics in children especially. So you can patient will be immediately arousable and have a faster recovery. Early feeding can be possible and early discharge can possible. But in spinal or segmental spinal, the most important criteria for daycare surgery, if you are using, it should be voiding before discharge the patient. And in infant and premature babies, especially avoiding GV, can reduce the postoperative apnea risk as well. So overall risks are low, but important to understand. Hypotension and bradycardia, less common but can possible. And so you should be ready with the resuscitative drugs. High spinal can occur with excessive dosing or unintentional cephalate spread. And post-durant puncture headache is very rare in children but can occur. Block failure or extending surgical time, you may require to convert the case into general anesthesia. Transient neurological symptoms, which are extremely rare, but with this model needle and the dosing and proper technique and monitoring can minimize this complication. So studies and clinical experience shows excellent outcome with the segmental spinal. So you may have a high success rate when you perform by the trained anesthetists, significantly reduce the postoperative nausea and vomiting and as compared to general anesthesia, and lower incidence of apnea, especially in children and ex-premature infants. Promote the enhanced recovery protocol. You can use it as a short procedure, as a daycare procedure. But as I mentioned, the wording, you should confirm the wording before the discharge of the patient. And when used selectively, it has a if you use a highly selective procedure, so it may be highly selective for the alternative to the general anesthesia. In this slide, I have mentioned some of the few surgeries and targeted site for the segmental spinal anesthesia, which I have mentioned earlier, the inguinal hernia, T12 to L1, umbilical. So you have to target the dermatome and mid-size, exactly you have to target the mid-dermatomal level. To summarize, segmental spinal anesthesia is a safe, reliable, and effective anesthetic option for selected pediatric surgery. It may require good understanding of pediatric physiology, accurate dosing, and careful monitoring and readiness of airway management at any time. So when you perform well, it significantly improves the airway safety and quality of recovery. Thank you for your attention. I'd be happy to take questions.
Yeah, thanks, Dharmi, for that talk, which I think many of us are yet to start doing.